The Pediatric Lounge, a podcast taking you behind the door of the physician's lounge to get a deeper insight into just what docs are talking about today. From the clinically profound to the wonderfully routine and everything in between. Welcome once again to the Pediatric Lounge. This is your host, Dr. Herb Bravo. Today we will be in the lounge with your co-host, Dr. George Rogu, and our guest, Dr. Cindy Rubin. Dr. Cindy is a pediatrician in the west side of Chicago and is a direct primary care pediatrician and lactation consultant. Let's welcome her to the lounge. Hi, George. How are you?
Herb, it's Tuesday morning, once again, elevating great physicians. And today we have Dr. Cindy Rubin, and she's going to talk to us a little bit about the transition from practice to DPC.
Welcome, Cindy. It's a pleasure to have you on the podcast.
Thank you. It's a pleasure to be here.
So you have a most interesting career path. You've been all over the country. So you started in Stanford and then went clear across the country to DC at Georgetown to get your MD. So you studied with the monks there. And
I did.
And then you went to one of the premier children's hospital in the Midwest at University of Chicago for your residency. And then you went back to the monks and went to work at Loyola University. So you've been East Coast, West Coast, Midwest. I guess next you have to go to Florida or Texas. But why did you become a pediatrician?
Oh, the big question. It's funny. When I was at Georgetown and was kind of trying to figure things out, I had a couple of very wise pieces of advice that I try to pass along to my med students. So they said, pick a specialty where every day, even on your worst, most boring day, let's say, boring cases, boring whatever, there's going to be something that you love. So in pediatrics, the kids, no matter, on your day of 10,000 colds, it's still kids. So that was first piece of advice. And then the second piece of advice was go into a specialty where you will like the other people who are practicing that specialty, which I also thought was very wise and really hadn't thought about it before. And pediatrics made sense. I mean, certainly it's a generalization, but every specialty certainly has its personality.
Right.
And it fits.
Wow.
Well, pediatrics certainly has a good work-life balance, I guess, compared to internal medicine. All my internal medicine friends, they're all miserable. Very few pediatricians are miserable. I like going to work.
Well, I do now. I didn't for a while, so thus my career path.
So at Loyola, you were a general pediatrician and also teaching students and residents.
Yeah.
And what do you think that the pediatric residencies get right and get wrong today?
So I wasn't so involved in the administration of the residency program at Loyola. I know from my own experience at University of Chicago, which was a while back, it was our program director was an incredible advocate for us as residents. She did whatever she could to make sure that we had what we need in terms of support, teaching, lunch, things like that really made us feel like we weren't just expendable, kind of slave wage workers. We were important and valued. And at Loyola, I feel like they do the same thing. I mean, I hear about it more from the residents, but the residents are happy, and I think it is because they are cared about, which I think continues into your professional career after residency as well.
And what do you think that residencies don't get right when it comes to training pediatricians?
Well, frankly, I mean, this may be me coming from the old school thinking, but I really do think that continuity of care is important. And when you're only taking, because the hours are cut short and you're not necessarily seeing a kid through an admission, you maybe admit them and you have to go home and you don't know what happens that next day. I think that really does make the learning process difficult, and it can make care not optimal as well.
Now, what I've noticed with the residents is because of the computer system. I mean, back in the day, or when you were in UB, what did you have? You had your book with all your information about everything. You knew each and every detail about each and every patient. Now, do you know how many times? Oh, let me look it up. They don't have to know, I guess, because they can look it up.
Yeah.
I don't know what's right anymore.
Look it up, and I think there's something about writing it down physically that
that definitely is. Yes.
Yeah.
They say it's and I don't think anybody does, but they say it's very important to continue writing because it's very stimulating to your brain. It's not the same as when you type on a keyboard. Just an off the cuff question: did you cross path with Chris Clardy? He's a nephrologist.
Yes, he was one of my attendings.
He's one of the most sarcastic but kindest human beings you'll meet, right? He used to say,
brilliant.
He is really brilliant. He taught me a lot. The first thing he taught me is, as soon as you get out of here, buy the biggest screen that you can, because your productivity is related to the size of your screen. And that's totally true. He says, forget about color. Back then, it was mostly black and white screens. He says, just get the biggest screen you can, black and white, because that'll help you do your work faster. He's very fun. And then he had another joke, which he used to tell the residents all the time. He used, the new residents, he would ask them, what's the difference between dog poop and a resident? And I was like, I don't know. He says, no one goes out of their way to step on dog poop.
Yeah.
All right.
And
there you go.
That was Chris Clardy's sarcasm. He's a great guy. Great guy. Love that guy. Tough nephrologist and intensivist. Really good. So you were at Loyola in something about organized medicine, not necessarily Loyola, I hope, but something about organized medicine no longer clicked with your values. What was it that started happening? Why did you no longer feel like you wanted to be part of a huge health system like UC or Loyola?
Yeah. I mean, it's funny because I really always thought that was exactly what I wanted. I didn't want to have to deal with the business side of things, and I wanted to do the teaching. And gradually, I started to feel more and more like I didn't have time, essentially. And it was funny because I wasn't sure what was changing to make me start running more and more behind over time. And I think it's because I got to know the patients better and felt less inclined to rush through things as I became a more seasoned pediatrician. And when I kind of entered my niche of the breastfeeding medicine, which I also practice, I really, really needed more time. And I just began running later and later clinic and tried desperately to figure out how to fix that and rectify it. But I can't not address what's going on in the room. And I'm really bad at saying, pick one problem, we'll deal with one problem today and come back another time, especially when we're totally full and overbooked already, because when are they going back? And so I would practice medicine the way I wanted to practice, and I would spend time with patients, but ultimately that hurt the patients who are waiting, my staff, and me and my family, because I wasn't getting home. I was staying incredibly late every day, both to finish up seeing the patients and then all of the paperwork and everything else that goes along with practicing in an office.
Do you think it was the computer system that did it? That made you delayed?
You know, it's funny. It's hard for me to answer that question because I started as an attending on computers. I started residency on paper. So I never really had that outpatient experience on paper. And I'm not sure. I see reasons why it does make a difference. I mean, I wouldn't have, I think people are much more abbreviated when they're on paper. And something about the computer allows you to put a lot more in than necessarily needs to be there and to take it with you, unfortunately. So I would be bringing it home all of the time.
Yeah,
Now,
but the
what
computer would allow you to pick an entire sentence where on paper you would write a couple of letters.
Right.
How can the computer be bad?
and so were you on Epic or Cerner?
I was on Epic.
On Epic, and that's not pediatric focused.
No. Right. So that might have helped if I had been on a pediatric focus.
And so
For sure.
over time you felt you couldn't do your job the way you wanted to do it. And I'm sure administration just kept saying you need to see these many patients and run in this time schedule in order for us to pay your salary.
Right.
Did you have an epiphany or a moment where you said, okay, this isn't working out for them or me, so it's time to move?
Yeah, I mean, it's funny because I really do think that there was something about the whole COVID experience that did make a difference for me. I had known for a while that it wasn't working at Loyola for me, and I was trying to figure out how to make it work. And when COVID happened and things actually did quiet down, we were seeing fewer patients a day. We were still seeing patients, but fewer. I was able to spend the time that I wanted to and needed to with my patients. And it felt good. And I made it home for dinner. And there were a lot of things that actually were working better during that shelter in place beginning of COVID. And when it was kind of like things just went from 0 to 60 in the fall, I think, like things just kind of opened up in medicine at least again. And I realized having been able to feel what it felt like to actually not be seeing 30 patients a day, I realized that I just couldn't do it anymore. And I needed something else. And I hadn't been sure what that was. I think that part of the problem leading up to that was that I knew something was wrong, but I couldn't quite figure out what was going to work.
So how do you decide that from being an employed physician at an academic center, you're going to go do direct primary care?
So first I was introduced to direct primary care. My first thought was, what? There's no way I would do that. I don't want to be a business person. Just a tiny, such a small practice. How can you survive? It didn't make sense to me. And thankfully I had friends in direct primary care who just kept feeding me the little pieces of all of the benefits. I mean, they were doing it, they were opening practices, And I was able to continually be reminded of all of the benefits of DPC. And I think it made me start to realize kind of system versus not system. If you stay in the system, no matter what you do, you're still kind of at the mercy of the reimbursement that you get from insurance companies. And that's part of what makes people end up having to see their education today. And for me, it felt like the only way to really practice the way I want to practice was to get outside of the system. And direct primary care makes a lot of sense, actually.
So you've been doing this for a year now as a direct primary care pediatrician and lactation consultant. What is it that you like the most about your new life at work?
So first of all, right now, I am doing all home visits, which I really love doing. You get to see patients from a very different, and families from a very different perspective. I love the fact that they are where they feel comfortable. Just in terms of pediatrics, it's so much easier to do a developmental assessment when a kid is in their own home and they can toddle around and show you their toys and play with their toys. And I think of myself when I take my kids to the doctor and I don't want them to touch anything. So that's a plus. I think it makes it easier to actually clinically do what we do as pediatricians, but in the home. But in general, it just allows me to, since I'm going to be paid directly, I don't have to worry about what I don't have to be at the mercy of the decisions of the insurance companies. I know that if I have this many patients, I'm going to get paid this much so that I can survive. And it also allows me, I was thinking for a while about having kind of a hybrid sort of practice where I charge a little bit less for kind of the monthly fee for the access to me, but then my patients would pay for the actual visits. But I realized that then would be a hindrance to people having visits. If you have this mindset of having to pay for each visit, people often will not schedule the visits. And that's what we see a lot of the time in the system is people have
I find it interesting that you allude a lot to the problem being the way the insurance companies pay the bills. A lot of physicians feel is the way the administrators run the practices. Because we talk to a lot of pediatricians across the country, and there are not many that are seeing 30 patients a day. 18 to 22 a day is more than normal.
Yeah.
So I just kind of wonder, was it just I know Medicaid in Illinois is a total disaster, because when I was there by April, they ran out of money and they wouldn't pay anything else. They give everybody IOUs. But do you think that maybe the clinic was not as efficiently run as a private office? Because 30 patients per provider is a lot.
It is. I do think that things could have been run better for sure. I did look at some other private practices that did have fewer patients a day, and I thought were run much more efficiently and effectively than the one that I'm in.
What do you think is the difference between those practices, the private offices and the academia center?
I think from what I could see, one of those things was the level of support of the staff for the physicians, the amount that the staff took ownership of and did behind the scenes make things run more smoothly for the doctors. I think that allowed doctors to focus on seeing the patients and not necessarily have to do as much of the paperwork and
So the support was better in a private office than it was in a center,
yes,
right? That's why in a private office, you see more patients because we have a million medical assistants, a million nurses, secretaries, and we see a lot of patients. Whereas you have people in the academic centers, they don't see a lot of patients, but they don't have support either.
right. Well, and where I was, we saw a lot of patients and we didn't have the support.
Yeah.
So then that's when you take work home and you stay late.
Right.
We have, we have a rule when I interview the doctors and stuff. I tell them that, pediatrics is like the weather. Sometimes it's rainy, sometimes it's sunny, sometimes it's a tsunami and it's snowing. Deal with it and adjust accordingly. And the goal is to go home on time and not take work home. What you see in between, whatever.
Yeah.
So you made a good choice for yourself, and you're happier, and I'm very happy for you in that sense. You've been at it for about a year, and I'm curious as to whether you're making money in this new venture.
Yeah, I am. I am not full where I hope to be at some point. I am making money. I am also still doing some side gigs, and I do get some loan money as well to help my family pay the bills at the moment. But I am growing, continually growing, and in a way, I'm happy that I've been growing slowly because it is a learning curve how to run a practice essentially. And so it's good that I've been able to work out a lot of my systems and iron some of the.
What do you do with a family that I presume they do a monthly membership or something like that?
Mhm.
They don't pay their membership. What do
Mhm.
you do?
So I haven't had that problem. I have some families that have had some financial issues. And that's the other nice thing about being able to be, being the business owner. I can make decisions, I can give discounts, I can give people the month off if they need it financially. But I haven't had anybody not.
Mhm.
So maybe I'm just lucky and I'm finding the right patients. I know that people do have those.
Yeah, and this is just a technical question. How do you know? How do you know that people are up to date on their monthly fee?
So it's part of my EMR. So I automate the fee goes out, and then I know whether or not it's been
Okay,
paid.
and are you an Atlas? That's the one a lot of
I'm
DPC.
not an Atlas. I am actually using Aero DPC, which is a newer EMR. I actually just switched to it. I had been doing everything by hand, and so I actually had a little Excel file where I had every single invoice I sent out, and then as soon as I got paid, I checked it off, and so I was doing it all by hand. So I'm finally moving over to something that's a little bit more automated.
Nice. What have I not asked you? Do you think it's important for pediatricians to hear from your experience?
I think the big thing is that I felt stuck for a while. I really didn't feel like there was any out. I felt like I had been where I was for a long time. I had patients that I had been taking care of since they were babies, and I didn't want to leave them because I knew that probably not all of my patients were going to follow me. And that was really, really hard. And I think as physicians, a lot of the time we put our patients before ourselves, and that's what I was doing. And I also was very just nervous about change, just being human, I think many of us are. And you can do it. Whatever that change is, if you know that what you're doing is not working for you, change it.
Yeah.
DPC might not be the answer for you, but you're not stuck. There are other options. There are private practices that maybe run more smoothly. There are ways to teach even when you are no longer directly in an academic center. I'm still teaching, and there's ways to do that. So there are other options. Find them, and that's one of the wonderful things about social media. There's a lot of bad things, but I think we can figure out what's out there and learn about things that we maybe never would have had access to before.
And so to your point, yes, I think that what people who study physician burnout say a lot is that there's a lack of self-compassion. And that lack of self-compassion added to the dysfunction of a not well-managed office and the, I would say, when you're seeing 30 patients, it's harder to deliver quality. And I think most physicians want to deliver quality. So you add all those three and people start burning out.
Right.
Who else do you think we should interview that you admire quite a bit in the pediatric space?
Oh boy. I mean, I thank goodness I had amazing colleagues at Loyola. Absolutely fantastic people who were my mentors. And I can think of one or two who, just from that perspective of practicing for such a long time and feeling like their patients are part of their family and they are part of their families. There's a physician in particular, Rebecca Barbado, from my previous practice, who I just think would bring a lot of insight to.
We would love if you send us an email introducing us to him, so we can have him on the podcast. Well, this has been very, very nice. Love having you with us this morning, and we wish you the best of luck with the DPC practice and the lactation consultant. I'm glad you found a place that you are happy, because that's important, so you can give the best to your patients, which is what we all want. Maybe someday we'll get a chance to see each other in person, but not in Chicago. I don't like the weather in Chicago.
All right.
When you come visit for your alumni reunion to DC, we can meet in Georgetown.
Actually, my sister lives in she lives in North Potomac, so she's in that general vicinity. So I'm out there at times, not a lot.
My parents live in Potomac, so
okay,
I'm very familiar. I'm very familiar with that. All right. Well, it's been a pleasure having you. Wish you the best of luck.
Thank you so much for having me.
All right.
Take care, guys.
Take care.
All right. Bye-bye.
Stop.